Good morning, everyone. I am Dr. Amit Soni from UNMICRC Hospital Cardiology. I am assistant professor here. Topic of today's presentation is on intravascular lithotripsy. So, agenda of today's presentations are impact of coronary calcium and unmet need for IVL, coronary IVL system and mechanism of action, coronary IVL clinical programs, CAD trials overviews, TCT 2021 highlights, and real world coronary IVL utilization, and IVL in eccentric calcium achieving optimal outcomes, and miscellaneous finally. So, impact of coronary calcium and unmet need for IVL. So, severely calcified coronary lesion and unmet clinical need. Coronary artery calcium prevents safe and predictable PCI. That heavy calcification increases the safety risk. Greater risk of procedural complication, including the major dissections and artery perforation. It also impedes the stent deliverability. Severe calcification is an independent predictor of not being able to implant DES and prevents stent expansions. The more severe the calcium, the greater the likelihood of a stent under expansion associated with increased ischemic events. So, PCI of heavily calcified lesion is associated with the procedural complication and or late adverse events. So, limitation and risk posted by the current technologies. So, current technology as a compliant, non-compliant balloons and atherectomy devices. So, there are many limitations with these devices, like non-compliant balloons has high pressure balloon preferentially expand away from the calcium, having limited effect on eccentric calcium. And high pressure inflation are often required to modify the calcium plaque and predisposing them to major dissections and perforation, often at in fact interface between the calcium and healthy tissues. Balloons are typically unable to modify deep and very thick calcium. So these are the limitations of non-compliant balloon using management of heavy calcium. Coming to atherectomy devices, atherectomy has a steep learning curve. Compared to the balloon-based therapies, ablation is contact dependent and may struggle in larger caliber lumens, as in unable to modify deep calcium also. It causes thermal injury and leads to increased risk of clotting. Unable to protect the side branch with a second guide wire, because we cannot use a side wire to protect the side branch during the rotablation. And potential to transect wires for large dissections and perforation easily in tortuous anatomy. And distal embolization is associated with the slow flow, no flow, and periprocedural MI. So these are the complications related with the non-compliant balloons and atherectomy devices. Opportunity for the shockwave IVL, a potential advantage of lithotripsy. There is no requirement for a specialized wire. Shock waves are selective for disrupting calcium. Shock waves passes through the plaque vessel, enable modifications of deeper lying calciums, disrupt calcium remains within the vessel wall, thereby reducing the risk of distal embolizations. And lithotripsy allows the calcium modification at low balloon pressure to avoid the risk associated with the high pressure inflation, able to protect the branch with the second wire. So we can use the second wire here. As with the balloon-based therapies, the shockwave IVL system is easy to learn compared to other forms of the calcium modifications. So it's a predictably safe, distinctly intuitive, and consistently effective. So, coronary IVL system and mechanism of action. So, lithotripsy for cardiovascular applications. There was extracorporeal lithotripsy, then intravascular lithotripsy come into existence. The miniaturized and layered lithotripsy emits the localized lithotripsy at the site of vascular calcium, optimized for treatment of coronary arterial calcification. So, shockwave coronary IVL system components it has a generator, connector cable, and a catheter. So, at the catheter tip, the integrated 12 mm semi-compliant balloons facilitate energy transfer, distal and the proximal marker bands, and 2 emitters that pulse once per second. So now 120 pulse per catheter is also available. So growing applications of intravascular lithotripsy web M for peripheral above the knee and transfemoral axis as during the TAVI and Impella use, and web S for below the knee procedures, and web C for the coronaries. So how IVL cracks calcium in situ? After inflating the integrated balloon to 4 atmosphere, a small spark at the emitter vaporizes the saline contrast solution and creates a bubble which rapidly expands and collapses within the balloon. This expanding and collapsing bubbles creates a short burst of sonic pressure waves. The sonic pressure waves travel through the coronary tissues while reflecting of the cracking calcium, and the effective pressure of 50 atmosphere is generated. The emitters along the length of the device creates a localized field effect within the vessel to fracture both intimal and medial calcium. The integrated balloons plays a unique role in apposition to the vessel wall, facilitates efficient energy transfer during the IVL, after which it is used to dilate the lesion to maximum lumen gain. So this is how IVL system works. So place a IVL balloon, inflate it up to 4 atmosphere. Now coupler to facilitate energy transfer. So IVL unique mechanism of actions, high speed sonic pressure waves created safely inside integrated balloon. Unfocused lithotripsy energy is created at the entire emitters which are contained in the fluid filled couplers. Electrical energy is delivered to the emitter, initiating the stream bubble which expands and collapses, creating the sonic pressure waves. So this is the video that shows how it works. So IVL designed to minimize the trauma while cracking the calcium. So it's a dictum that hard on hard and soft on soft. So the sonic pressure waves in the right side video shows propagating through the body and negligible disruption of energy and thereby damage owing to the minimal difference in density of soft tissues. On left side videos we can see that this is a hard on hard. As the calcium interface, the relatively large difference in density coupled with the contraction of multiple shock pressure waves in a small area produces a large dissipation of energy. So it is hard on hard. So OCT image shows large multiplane and longitudinal calcium fractures. So luminal gain, as you can see in OCT images, is remarkably significant. And OCT imaging shows luminal gain. Here shows the cracked calcium. The microfracture occurs beyond the resolution of IBS and OCT. The cadaveric superficial femoral arteries of micro CT shows pre-IVL. We can see there is no fractures are visible, while the post-IVL the white arrow shows a crack of the calcium and fractures. So coronary IVL system setup. So working length is 12 mm. The balloon working length is 12 mm from the inner edge to marker bands, and 6 mm between the emitters, and 4 mm and 2 mm between the emitters and marker bands. And acoustic pressure declines 3 mm away from the emitters. So here the smooth energy profile over the entire 12 mm balloon is gained. Optimize the overlap. Coronary IVL clinical programs. So coronary IVL clinical programs, excellent outcome in core lab adjusted studies and disrupt CAD1, CAD2, CAD3, 4 and CAD and pooled analysis also. So consistent outcome across the disrupt CAD1, 2 and 3, we can see that the target vessel revascularization is required in merely 1.1% in pooled analysis, and 30-day MACE is up to 7.3%. Severe calcifications and pooled success all have the consistent outcome across the disrupted CAD 1, 2, 3 and 3. So coming to the disrupt CAD3 study design, prospective multi-center and single-arm global analysis. Objective was this study was to design to access safely and effectively the Shockwave medical coronary intravascular lithotripsy system. Performance goal based on the Orbit 2 primary safety endpoints, 30-day MACE rate at 30, the primary effectiveness endpoint less than 50% residual and no in-hospital MACE. Enrollment 384 subject across the 47 sites. Sub studies OCT, PPM, ICD and hemodynamics. Follow procedural 30 days, 6 month and 12 month and 24 month. So angiographic and procedural characters of severely calcified lesion with long length calcium. Core lab analysis has target was LED-L6 RC and LM has significantly calcified lesions, and calcifying length was 47.9 plus minus 18.8. Severe calcification was 100%. Primary safety and effectiveness endpoint exceeds. 30-day freedom from MACE were 92.2% and procedural success 92.4%. The primary safety endpoint met: freedom from 30-day MACE, cardiac death, MI and target vascular revascularization, one-sided lower 95% confidence interval and 89.9%, more than pre-specified performance goal of 84.4%. The primary effectiveness endpoints met, and procedural success, sustained delivery with the residual stenosis less than 50% without in-hospital MACE, one-sided lower 95% confidence interval and 92.2 as compared to pre-specified performance goal of 83.4%. So angiographic outcome and complications. The luminal gain post-IVL and post-stent with the minimal complications. So we can see that finally any serious angiographic complication is merely 0.5%, severe dissections 0.3%, perforation and abrupt closure and perforation merely 0.3% finally, and slow flow, no flow 0%. In hospital 30-day MACE. In hospital 30-day MACE you can see no evidence of learning curve with IVL. Role inpatient represents the first case for each site of study. Baseline clinical and angiographic characteristics were similar between the two groups. Key study outcome were similar between the roll-in and pivotal patients. So key takeaways at 30 days of disrupt CAD3 trial. The CAD3 confirms the IVL safety with low rates of major periprocedural clinical and angiographic complications, setting a new bar for safety in complex coronary lesion. 92.2% of patients were free from MACE at 30 days. Low risk of perforation 0.3%, major dissection 0.3% and abrupt closure 0.3% with no slow flow and no reflow. CAD3 showcases IVL effectiveness with large lumen gain that facilitates stent delivery and optimized stent expansion. 92.4% procedural success rate defined a successful stent delivery, 99%. Residual stenosis is less than 50% in 100% cases without in-hospital MACE. Successful IVL crossing and thereby delivery in 93% lesion correlating with 99% stent delivery. CAD3 demonstrate coronary IVL's ease of use and a quick learning curve to achieve the consistently predictable outcome. disrupt CAD3 by the numbers. US pivotal study conclusion. Disrupt CAD3 trials success was achieved in both primary safety and effectiveness endpoint were met following treatment with coronary IVL in severely calcified lesions. Coronary IVL prior to DAS implantation was well tolerated with a low rate of major peri-procedural clinical and angiographic complications. Although this study represents the initial coronary IVL experience with US operator, high procedural success and low angiographic complications were achieved, reflecting the relative ease of use of IVL technology. OCT demonstrated longitudinal and circumferential calcium fractures in heavily calcified lesions, resulting in increased vessel compliance, large post-procedural MSA, and excellent stent expansion. Minimum stent area stenosis and stent expansion outcome were excellent regardless of calcium fracture visualization by OCT and may represent a limitation of OCT to detect the subtle microfractures or out-of-plane fractures in calcified plaque. So the consistency is shocking. The disruptive clinical evidence from TCT 2021 consistent over the time, consistent across the calcium arcs, consistent in calcified nodules, and consistent between men and women. So how it is consistent outcome over the time? Intravascular lithotripsy treatment to severely calcified coronary lesion 1 year results from the disrupt CAD trials. 1 year outcomes, we can see the MACE longest analysis of coronary IVL confirmed the consistency of the excellent safety and effectiveness resulting in severely complex calcified lesions. You can see that MACE, cardiac death, TVR, and the MI. So low target TLR and a late stent thrombosis rate demonstrated durable safety and effectiveness. Consistent MSA and expansion across the calcium arc. So pooled OCT outcomes across the disruptive CAD 1, 2 and 3, 4 and excellent MSA in a stent expansion with no procedural complications seen in total 262 patient, severe calcification in 98.4%, calcified length is 43 mm and MSA achieved is 6 mm square, stent expansion 103%, procedural complication 0%. So consistent MSA and stent expansion across the calcium arc. Similar outcomes regardless of the visible OCT calcium fractures. The greater the amount of the calcium, the more fractures are generated. Microfracture evident beyond the resolution of OCT. You can see in pre-IVL cases and post-IVL cases. Consistent MSA and expansion in calcific nodules. So calcific nodule found in 22% of calcified lesions, most commonly found in RCA on bands, often associated with concentric calcium. Different types of calcium nodules. There may be eruptive nodules or nodular calcification. Eruptive nodules, accumulation with small calcium fragments with irregular surface and adjacent proximal and distal deep seat of calcifications. And while in nodular calcification, that is a healed calcified nodules, accumulation of small calcium fragments with a smooth thick fibrous cap with adjacent proximal and distal deep seat calcification. So in pre-IVL calcified nodule and post-IVL and post-stenting, here OCT is viewed. Consistent MSA stent expansion with or without calcium nodules. Here are the images. Pattern of stent expansion with IVL in calcific nodules. So concentric expansion seen in deformed eruptive nodules in 34% cases. Concentric expansion deformed nodular calcification in 43%. And eccentric expansion in non-deformed nodular calcification in 23% cases. The consistent outcome in men and women. So female fare worse than men when treating calcified lesions. Female gender is an independent predictor of adverse clinical events after the PCI lesion with the coronary artery calcification. Women may be particularly susceptible for procedural complication following atherectomy due to the gender-specific difference in coronary pathophysiology. No difference in primary safety and effectiveness outcome seen after IVL use. Similar angiographic complication despite smaller RBD in women. So coronary IVL TCT data, what did we learn? Early excellent 30-day safety and effectiveness results remained durable 1 year to 1 year. Due to its unique mechanism of action, IVL achieved consistent, excellent MSA and stent expansion across all arc of calcium, both concentric and eccentric, regardless of the calcium burden or whether visible fractures were identified under OCT or not. IVL can modify nodular calcium effectively to achieve large MSA and stent expansion, known predictors of positive long-term outcome. In eccentric and nodular calcium with expected higher acute risk, IVL restored vascular compliance without any procedural complications. Due to its exceptional safety profile, both women and men equally benefited from coronary IVL in severely calcified lesion, unlike atherectomy. Real world. Key learning from the over 3 years of international experience. So more than 45 countries offer IVL to their patients. More than 25,000 patients treated since 2018. More than 60 publications in peer-reviewed journal and more than 1,200 patient outcome in publications. So eccentric and concentric calcification, superficial or deep, IVL is the answer. So high value IVL application to treat the complex calcium with ease and predictability. There is a left main with large vessel and bifurcation or tortuous or ostial lesion. Anywhere the calcium is broken by IVL. So a simple algorithm to simplify procedures, calcium identified. So tortuous or angled anatomy, focal or diffuse, single or multivessels, eccentric or concentric, intimal or medial, thin or thick, bifurcation or osteal disease. ANSI balloon, if ANSI balloon failures, IVL is the answer. It minimizes the cost, minimizes the dissection, minimizes the trauma. So how coronary IVL is typically integrated into clinical practice? So first we should assess with the CT, angiography, intravascular imaging or dog boning during the PTCA procedures. And if the heavy calcium is seen, the calcium angle more than 180 degree, thickness more than 0.5 mm and length more than 5 mm. So do calcium modification and first try the ANSI balloon, and if it is not working, then directly go to IVL. If it is not crossed, then use the guide liner, or we can use the Lithotripsy or atherectomy devices, then we can use the IVL. So coming to the cases of multi-lesion RCA. The multi-lesion RCA could not advance the guide liner to distal lesion despite pre-dilatation. Advanced 3.5 IVL catheter as possible, derived 1 cycle 10 pulses and vessel opened. Pulled back to ostium and vessel opened after 1 cycle of 10 pulses. Advanced distal lesion and the vessel opened after 1 cycle, easily delivering 80 mm of DES. So case of unprotected LM trifurcation. Summary: unprotected LM trifurcation with a heavy calcification throughout the LM, LED, LCX and ostia of a trifurcation, hemodynamic support, the temporary pump IVL administered along the LED, LCX and LM and the ostial of LCX and LED and ramus. DES placed in LM and all three vessels with a good expansion and apposition of demonstrated in OCT. So case of bifurcation in LED, severely calcified mid LED involving the signal. Occluded ostial RCA, nearly occluded RCA that was planned rotablation case. However, the guideliner went through the 3 mm IVL catheter, followed and opened up nicely after the 40 pulse. Once the RCA was opened up, we realized we undersized the balloon 3.5 IVL and 80 pulses in the 2 ostial segment implanted a 3.5 into 18 DES finally. Angulated LCX. Highly angulated LCX with the lesion proximal and distal OCT would not cross either lesion guideliner. Assisted IVL catheter delivery followed a successful IVL therapy. The case was completed with ease and deployment of DES. And IVL after unsuccessful rotablation. So ACS patient with the calcified LED and RCA, heart team deemed to be high surgical risk and recommended the stage PCI at proximal LED in first, and pre-dilation semi-compliant balloons failed to dilate. Rota ensued with a 1.75 mm burr. However, there was persistent balloon under expansion, so 3 mm IVL pulled with immediate waist resolution, pre-dilated, expanded, and 3.3 into 48 DES used. So IVL and eccentric calcium achieving optimal outcome. So different challenges with different type of calcium. So concentric calcium, there is a napkin ring typically resistant to high pressure balloons, and in the eccentric calcium, non-calcified vessel wall susceptible to dissections. So I will perform differently but enables optimal outcome across all types of calcifications. So here is a eccentric calcium and a concentric calcium. So eccentric calcium, fewer fractures but similar stent expansion. We can see as disrupt CAD1 OCT sub-study was done, and concentric calcium lesion correlate to the more fractures than eccentric lesion, and similar outcome across the eccentric and concentric lesions. So consistent clinical outcome in eccentric and concentric calcium. Stable angina, unstable angina, or silent ischemia, moderate to severely calcified de novo coronary lesion. So IVL is effective in all spectrum of calcifications. Coming to the miscellaneous, use of IVL in under-expanded stents. Our current indication is for the de novo severely calcified lesion prior to stenting, and our labeling include the following. Precaution statement. Precautions should be taken when treating a patient with the previous stenting with the 5 mm of target lesion. There are potential impact on the stent integrity as a result of the hydraulic lithotripsy discharge occurring in close proximity to the stent. Bench testing has been performed on DES to mimic the acute setting newly implanted under expanded stent that is not endothelized. Results were the damage to the polymer layer was observed, polymer spalling and peeling of the stent, removing the patches of coating, and also the pitting damage of the coating and potentially to stent was observed. So potential IVL impact on heart rate and rhythm and implantable devices. The stretch of activated response from the acoustic pressure waves produce extremely low amount of energy, that is 8 to 10 microjoule, lower than the required to induce the ventricular fibrillation, that is more than 500 microjoules, or cause a damage to implantable device. So it is safe. If the patient heart rate is less than 60, IVL may become a faster pacer for 10 seconds during the delivery of pulse.